Hello, welcome to this video. This is a pre-recorded lecture on health promotion. It's part of a series of videos on health promotion, and this is the first video which is really introducing health promotion and exploring what the concept means, looking at some of the issues around health promotion and setting the scene for more content on health promotion. So let's get stuck into the slides. So first of all, we're going to consider what is health promotion. So health promotion as a term is often used interchangeably with public health, health interventions, health development, and yet it can mean different things to different people at different times. It's been described as a social movement, or thought of as a social movement. Is it an ideology? Is it a discipline, a strategy? Is it a profession? We have health promotion professionals or health promotion practitioners. Or is it a strategy? Is it a type of strategy that can be deployed at different times by different public health professionals? Or is it a whole field of practice? Are there separate values and commitments that people will make as a health promotion specialist, different ways of working than there would be if you worked in public health as a named public health professional or for a public health organisation? And also it gets used in allied, what we could call allied professions. So we'll see aspects of health promotion in nursing and the allied health professions, such as physiotherapy and so on. So we need to think about what it is, where it sits amongst public health. So whilst public health practices and what could be seen as health promotion practices have been present for much of human nature, or human history rather, really the term in terms of professional use really only started being used around the 1970s, 1980s, and we'll look a little bit later at the World Health Organization and their input in the development of health promotion. But back in the 70s, 80s, as soon as the phrase was being used more institutionally, then as soon as it came into being, there were commentators that were identifying the issues with the term health promotion. And so I've got a quote here in Tannehill. In 1985, Tannehill described health promotion as a meaningless concept because it was used so differently. So that doesn't mean that the practices are meaningless, but possibly the term might be meaningless and confused. And then Seedhouse, slightly later in 1997, published a book on health promotion, talking about its place and its role and what it actually means to people, but described the term as muddled, poorly articulated, devoid of a clear philosophy. So these are criticisms that were aligned or aimed at the concept of health promotion almost as soon as it became more formalised. And they're criticisms that could still stand now, but in order to have a good criticism, sometimes things are defined by the things that they're not, or the critiques of them. So this all takes place in the discourse of around what is health promotion. We need to look at what is it not, just as much as what it is. Similarly, being described as the slick salesmanship of health, and it's all of those attempts that we make to cajole or to persuade people to change behaviour. So when we start looking at definitions, quite quickly we get into issues of personal responsibility and control as well, and one person doing something to another. There's issues of individual responsibility and the often overused word lifestyle, and even behaviour change. I spent many years explaining my relationship with this word lifestyle and trying to get my students and fellow professionals to think about what we mean by lifestyle. I'd progressed on to the broad umbrella term of behaviour change in this space, but more recently I've looked through different lenses at even that term, and that concept of behaviour change does the aim justify the means, and what do we actually mean? How much are we doing things to other people? These are all classic public health issues. But what we're going to look at in the next few slides is the relationship with public health and health promotion, and there are many issues which overlap. But there are also some issues which classically don't quite overlap and make health promotion a distinct concept. So I'm going to spend a few minutes looking through health promotion in this country, which most of us a bit more familiar with. And then also, you can't consider health promotion without looking more globally as well. So I'm going to start off this slide with classic Victorian era, mid to late 1800s. This is not going to be loads of history, by the way, but mid to late 1800s, and that move from a rural economy into a more industrialized economy, and that mass movement of people into big cities that was accompanied by the response of seeing new illnesses and the speed at which illnesses were being transferred, and the parallel situation where there were many people who had extraordinary amounts of money and were able to be patrons for various different reasons of public health schemes, which would promote health in terms of that health communication message and that education, but also to make changes to infrastructure. And I have a picture of Joseph Bazalgette's underground London sewage system, and the cost of this and the impact of it. These are significant improvements in something which could be called health promotion or public health. So it would be naive and it would be foolish. It would be easy as well to start off here in terms of health promotion in the UK, but that's not to ignore ancient Greeks, Hippocrates. The ancient Greeks saw their health function of physical and social environments bringing together. They were interested in empowering communities. Hippocrates saw health as the equilibrium between environmental forces and individual habits, and one's most valuable asset was health. And then obviously we look at Joseph Bazalgette's sewage system, and we can look back to the Roman times and look at the work that they did in terms of paving streets, clean water, waste disposal systems as well. From ancient times we can jump and pass briefly through medieval times, where we look at issues around plague and quarantine, and an interesting perspective thinking back to then and looking at some of the practices and policies that were put in place to try and prevent the spread of plague around the world, and people being put into 2-week quarantine as well, and the various infrastructure changes that took place as well. Again, we're looking at public health, health promotion, and there's a very blurred line in between the two. If we bring it back to England, modern history, or Great Britain, and we look at some of these industrial responses to ill health and their place in health promotion, then we get to the development of organisations such as the London Statistical Society, the Manchester Statistical Society, the temperance movement. They're different drivers on some of these organisations and some of these health actions. The statistical societies grew up in small pockets around the country, and have developed into what we know now as the Royal Statistical Society through various circuitous routes, but born out of a desire for patronage and altruism, but also efficiency in terms of workplace, and so sometimes coming from more of a need to have a healthy resource in terms of the employees, and what was limiting productivity in terms of illness and absenteeism. But this blurred line between a work-based need for information and an altruistic desire to have a healthy community exists in these organisations that take place. And it's only when you start to look at some of the to produce data and look at information that we can start to see patterns. This is the origins of modern public health, if I'm to mix the terms at the same time. So 1920s, see what's coming up next. 1920s, 1900s, 1920s. The concern of health promotion turned towards a response to the First World War as one big example, based on impact and numbers. So in terms of the severity of disease and the numbers of people with disease, 10 to 20% of World War One soldiers apparently would return with venereal disease, and so in terms of the numbers involved and the impact on the community, this was quite rightly identified as an issue worthy of attention. One of the responses to that would be around the production of mass posters, mass action, which was applied to the whole country as a means of an efficient way of trying to prevent further ill health and to try and change behaviour. The classic health education as health promotion actions. In 1927, Central Council for Health Education was set up, funded by local authority public health departments, and again the emphasis was on posters and health education, trying to inform, and that underlying notion that if we can educate people that they will change their behaviour, which is a very valid part of the jigsaw, but the emphasis on this education has changed over those years. The Central Council for Health Education became the Health Education Council. So 1968 set up with a remit, and I'm going to read off my notes here again, to develop a climate of opinion generally favourable to health education, develop blanket programmes of education and selected priority subjects. So there's some interesting terms in that phrase. To develop a climate of opinion generally favourable to health education. So this to me sounds, and to further analysis, it's not just about the health education knowledge itself, but to work on the broader climate that health education as a process is an acceptable process to the wider population. To work on two levels at least of setting the scene for people to receive that message, but also then to send out that message. The concept of having a selected priority subjects suggests a kind of rationing for whether that's for resource or whether that's for mental capacity of the population that we're targeting, for want of a better word. I love the old health education adverts, but lots of stories to be told, lots of reflections on how well those promotional campaigns worked. People that were around at the time, and I was not quite around for the early 1970s one, not consciously anyway, but the AIDS adverts of Don't Die of Ignorance I was certainly conscious of at the time. And the message within some of these campaigns is an interesting message to reflect upon, and there's lots of work on the Don't Die of Ignorance message, and then the concept of messaging as an intervention that is going to work is also something that we can reflect on when we look back, and then when we think of messaging now and how we use it, and how we use it more efficiently as well. More recently, the move rather from those first stages of social hygiene and sanitation, which is often known as the first wave, and then the second wave of public health and health promotion, is about that health education messaging. It's more of the individualized approach. And then as we moved into the 2000s, the critique of those 1970s late 20th century messages was that messaging is fine, but there's an intention behaviour gap where, well, first of all, people have to respond to the message well. So the messenger has to be believed, the message has to seem relevant to an individual, and then they have to change their behaviour or want to change their behaviour. The social norms need to be in place, and then there needs to be an intention to change, and then there needs to be the delivery of the change in behaviour. And everything I've just talked about is very focused on that individual, but clearly we need to be looking at the environment as well and community level change. And that's where the complexity, the foresight model of obesity was a major milestone in this change from thinking that there are simple cause and effect straight lines which we can draw from knowledge levels and social environment to changes in behaviour. And that complexity of systems and the competing tensions on groups, communities, policy, individuals, and now if we change one facet, there will be another facet which will pull in different directions. And so over the last 10 years, health promotion has developed this critical awareness of systems level approaches. More broadly, it would be inappropriate to look at health promotion without paying attention and reviewing some of the major milestones that have happened over the years, largely focused around World Health Organization. And one of the World Health Organization's main roles is in this coordination of different countries. And one of the problems would be the tension between developing countries and issues of equity and targeted healthcare and non-communicable disease, with the same but more some of the same issues but at a different stage of maturity. So if we look at tobacco consumption in developing countries and then look at more Western countries and then more developing countries, we can see that they're several years behind us in terms of the level of education and the profusion of knowledge and the policy which are in place to try and fend off those large corporations which are trying to sell tobacco to the populations, to the masses. It's the World Health Organization that plays one of those roles. Oops. Clicked the wrong thing there, didn't I? There we go. So some major staging points in the 70s were what's known as the Alma Ata Declaration, which was one of the first international declarations to underpin the importance of primary healthcare. And that's not to say primary as in GP, but primary as in the importance of healthcare and the way that it overlaps policy. And we have policy for good health and in all policy. So the concept of health for all grew out of this, which was a major milestone in the 20th century public health. And then we've got the Lalonde Report in 1974, so focused in Canada, and was one of the first significant global reports of global importance, which suggested that the over-reliance on the medical model of health and an increased focus on dealing with ill health and having the right type of health infrastructure, it completely ignored the concept of preventing ill health and the integration of government systems, infrastructure, community in providing the right environment for good health. So Lalonde looked at health, broadly health, breaking it down into human biology, environment, lifestyle and healthcare organisation. And that's where we've got lifestyle and environment being in that health promotion space. And I've already offered up the fact there are criticisms of lifestyle as a term. But then we got to health for all, which was about more countries adopting more principles, key principles, top-level principles, which are looking at lifestyle and health and trying to create those right environments. And that we have collective behaviours of populations, and the individual works within broader context. So these set the scene really for these series of different global conferences on health promotion, which started in 1988 in Ottawa, progressed right through to China in 2016. Where are we? It's not on my board, but 2016. Oh, there we go. 9th, 2016 in China, and that perspective of what is health promotion on a global scale, so both in different areas with different needs, but broadly across the top as well. How health promotion, who should be responsible for health promotion, and how we should be promoting good health, both in terms of environment and individual perspective. Ottawa, Canada, major milestone in terms of health promotion definitions and actions. So this was one of the first redefinitions and repositioning of institutions, and was in line with what's known as the salutogenic approach by Anton Antonovsky. That idea that good health is something which is more than just the absence of illness, and there is it's a holistic approach. And this was born out of those previous attempts, previous considerations by the World Health Organization. But we're coming out of the 70s, so we're looking at self-help movement, women's health, the gay rights movement as well. And in terms of we're thinking of concepts such as empowerment, and that ability for people to say themselves as a community what health means to them, and have different perspectives in different communities, and have a role in creating those right environments in their communities for good health. There's loads of good stuff on the gay rights movement in America, particularly of the 70s and 80s, and I'd encourage you to look at some of the BBC Sounds documentaries, which hopefully were still on there. They were on there last week when I was having a listen. There's some brilliant stories about people coming together and building an identity, growing a self-identity, and empowering themselves to make changes. And some of the stories of them invading some of the pharmaceutical companies and demanding the cost of medication be brought down are just one brilliant example of that sense of empowerment. So the importance of community action, things like needs assessment, joint planning, capacity building, these are all issues. And you can see from the diagram, the classic Ottawa diagram, that the first principles of enabling, mediating, advocating are enshrined in the World Health Organization Charter, the Ottawa Charter. So that enabling about giving people the right skills, the right environments, advocating, shouting about creating the right, sharing knowledge, and trying to make change, and then mediating, so trying to bring together different government, community organisations and make people play their own role in the broader picture of health. So again, we're talking public health, but this is the World Health Organization global conferences on health promotion as a concept. And some of the actions, you can see the 5 classic actions are also on the charter of strengthening community action, developing personal skills, creating supportive environments, reorientating health services as well as part of this, and building healthy public policy. Very commendable aims, which World Health Organization level are not easy to come up with as a consensus, and similarly complex in terms of implementation and delivery. So to reflect on what health promotion actually means to us, one of the simplest definitions, and I like it because it's so simple, because I like simple, is that idea that public health is the broader concept, not just an organisation, but concept. And health promotion is about changing behaviour. There you go again. Is about engaging with populations and communities, working out what health means to them, working in community development and support to empower them, and then to allow them to be part of creating the right environments for a change which is beneficial to their health. Whether that change is their own individual change, that they are changing something and the main thing they're changing is their behaviour, but more than likely it also refers to those broader environmental issues. And what I've tried to describe in terms of health promotion there is something which there are many different versions of it, and our political ideology, the ideology of where the organisation that's delivering health promotion, where that sits. There are many things that we do, I think, in health promotion and public health, which we feel are inherently just part of what public health is, but they've not always been the same. And it's always good to stop off, and hopefully on these courses we'll be able to stop off and kind of question why is that the case? What's the alternative practice? Why don't we just get on with it and tell them what to do or ban it? What is not health promotion traditionally is often thought of health as health protection. So health protection being traditionally, and I speak in September 2020, in a unprecedented time, but health protection traditionally has been that kind of more medicalized, more more to do with the rules and regulations, more about notifiable diseases, and the identification of people that are ill but exist in the community, and immediate sharp action is needed to stop that spread. And it's always been a bit less about behaviour, but there are crossovers, and we'll look at some crossovers in a bit. So in terms of ideology and values, we'll do more work on ideology and values and the ethics of health promotion. But we're issues of utilitarianism. So does the end justify the means? Paternalism. Are we right? How much are we placing our values on someone else? How much are we, whoever we is, in power? And it's our belief that a certain type of behaviour is good for this group. Smoking being one of the classics. Easy to look at different populations and look at how much they smoke, and to know that smoking is inherently bad for us in terms of the percentage chances of ill health. But what right do I have to tell someone else not to smoke when they've got plenty of other things going on in their life? And at that point in time, smoking is what they perceive as being good for their mental health. So how much do I coerce them into changing their behaviour? How much can we change behaviour? How much is our rationality and our rational choice bounded by our bias and the amount of information that we have at our disposal? These are all issues around health promotion. Get that one up there. When we think about different types of health promotion, different actions, then I always find the Nuffield ladder of interventions really helpful there, and hopefully you can read that or you can Google it. We start at the bottom with doing nothing. So doing nothing is a choice in terms of health promotion. If we identify that there's a problem, then we could do nothing. If we might be making that choice based on resource, we might be making it based on a priority level, which is resource, and then the interventions go right through and up into eliminating choice. So we can ask ourselves, where do we think health promotion sits in this Nuffield ladder? There will be different types of health promotion intervention, and if we think about what types of interventions are health promotion, where will those individual choices sit? We've already touched on issues of coercion and what's acceptable, and I'll leave you to look through the other issues on the slide. Gutman produced a really good paper on the ethical issues in health promotion and communication intervention. And when we're thinking about what is health promotion, it's really beneficial to look at what's appropriate in terms of health promotion, and this will vary different places, different times. And we're right in the thick of one very important time at the moment. But we need to ask ourselves, does it actually promote better health? And who is of most benefit to that? And if we think back to my smoking example, then we could question that. Other issues that pop up in health promotion over the years include victim blaming and stigmatization. The classic adverts of overweight people in posters to try and appeal to people that are overweight and present different alternatives, and to try and nudge changes in behaviour can often result in stigmatization. And there's a whole body of work around that in terms of health promotion, and the fact that the actions that we feel are the right actions could actually have alternate consequences. So at the start I said about what is health promotion. Is it an ideology? Is it a role, a practice, a set of strategies? But there have been consideration given to what it is in terms of a set of practical skills. Now, the International Union of Health Promotion and Education is worth a look up on the internet, and a few years ago set out to explain what are the core competencies that a health promotion professional or a professional who has health promotion within their role needs. And so you can see the advocate, enable and mediate still with us from Ottawa in 1986. So this is 30, my maths is right, 30 years later. Those have stuck as key pillars of health promotion. But you can see around the outside those skills that are said to be needed by health promotion practitioners are around needs assessment, planning, implementation, evaluation and research, communication and leadership. Allied to the work that we're going to do over the next sessions and weeks is look at the intervention mapping as a program, intervention mapping as a framework for delivering health promotion programs. There's been lots of work recently over the last decade about how we can bring in health behavior theory into health promotion and how we can strategically and systematically create the right type of health promotion intervention. That if we were to, I thought I might see Broff and Bremer's. Let me do a quick. This could all go wrong. Here we go. There we go. So if we look at this is one of my favourite diagrams. It's the simplest way of thinking of the socio-ecological model and is most related to Broff and Brenner's socio-ecological diagrams and similar to Dahlgren and Whitehead's. But it lays out the way the individual sits within that social network, broader organisational community, public policy. Health promotion often has been thought about this individual, about changing knowledge, attitudes and skills. But it's become clear both if we think public health and health promotion are different or the same, it's clear in both increasingly throughout the last 3-4 decades that it's these broader socio-ecological factors which the individual operates within, and that health promotion programs can try to aim their action at different levels of this increasing can you have an increasing onion? The increasing circles of the socio-ecological model. Alongside these theoretical reflections on health promotion, we'll also be looking at those practical skills of how we bring in theory, how we plan our programs, how we gather the best data, how we create that we properly identify the problem and then try and draw on the best evidence, the most appropriate evidence to create a solution, how we think about implementing an intervention. It's all very well having an intervention in place, whether that be at an individual level or community level, but to have to implement it in practice and in different locations, in different contexts, it's all about implementation. And we can plan for that implementation. There is guidance, there's research, and there's good practice insight into that. And that's what we're going to look at in conjunction. Those would be identified as the core competencies and skills. I think it's worth thinking about what health promotion is in 2020, and there we go. I have pictures of people wearing masks, and it's about the what I've been thinking recently about health promotion is how that original model of health promotion and health protection, where the gaps are in that model, where the overlap is. Sexual health as an area of work is an area which has often overlapped the health protection and that kind of medicalised response and intervention with a need for a health promotion intervention as well. That health promotion having health education as a key part of it, but being much more than health education. Trying to change social norms, trying to empower people to be able to use the knowledge that they have in practice as well. And I think there's lots to be learnt from sexual health in terms of in our response to coronavirus. Previously, communicable diseases in England particularly have been dealt with so efficiently, perhaps, in terms of the notifiable diseases. We've got to that point where they're so distilled in our community that the response can be impactful and has worked. But the coronavirus situation has presented us with a communicable disease which is we don't have the capacity to deal with in our existing systems, and whilst those systems are being expanded to deal with it, they need to work in partnership, and they need to harness that insight and knowledge that is traditionally always been a health promotion issue. So when I look around and I see people being blamed for poor behaviour, and I work a lot with 20-year-olds generally, and when I see people being blamed, I think back to the health protection model. I think back to the health belief model, and I think you need to believe that you're susceptible to an illness. You need to believe that it's going to be bad when you get it. You need to believe that you can take action, and you need to believe that you're capable of taking action. You know what the action is, and you can take that action. If we look at younger people, over August, September 2020, up to that point, there and probably still now, there are many people who don't know someone who's had coronavirus. So we see it in the news all the time. We can see the statistics, but if you don't know anyone that's had it, let alone know anyone who's had it, and it's been really bad for them, then the chances of you making certain changes to your behaviour, which are quite restrictive, are limited. It sounds ridiculous when we see it all over the television all the time, but if we can look at it the other way around, if someone's twin sibling had caught it in an innocuous way and in the shop and died from it, then I can guarantee that my behaviour would be different than someone else who has not had that experience. And there are obviously various levels through that. So health promotion, what is traditionally health promotion knowledge and capabilities, increasingly can be delivered or applied in this current setting which we're in, and who knows how long it's going to go on for. So Susan Mickey wrote a good, see if it's coming up here, there we go. So Susan Mickey, who has been at the forefront of collating and widening the impact of health behaviour change theory over the last decade and more, has applied that knowledge to this, what is traditionally a health protection setting. And you can see some of what the learning suggests that we should be doing in this time in terms of health promotion. What I would see as a typical health promotion intervention. So by presenting people with a clear rationale, we're more likely to motivate them to change. So you need that clarity. Creating social norms, so helping people to change their self-identity, and build intervention actions into a strong identity and not necessarily a negative self-identity, and giving people feedback, giving other people feedback as well. When we give out messages and health education messages, we need to couple those messages with concrete advice. And similarly, like the fear message that often comes with cigarettes, that fear message needs to be accompanied by a phone number to something to act. Otherwise, the fear message just gets ignored. And similarly, if we're going to give out health warnings, the health warnings on their own, health promotion insight tells us that without specific advice, people won't take action. Similarly, rather than just dropping behaviours and just not going to the pub, for example, the health promotion, health behaviour change advice suggests that if we have something to replace that with, so we make a positive change to remove one type of behaviour, but to replace it with something else. Lots of work around smoking has been done in that space, and the fact that for biological, psychological reasons, if we feel like we need a cigarette and we're trying to give up, that going for a walk has been shown to have an effect, which means we're less likely to need that cigarette. So it's a replacement rather than just not smoking. We're going to try and replace it with a different action, and then making that behaviour easy, and that allows me to bring up the kind of nudge principles, which again is is a well-grounded health promotion intervention in my eyes, making the healthy option the easy option. Oh, I pressed the wrong thing again. Here we go. So there's the link, if you want to see the link. Similarly, trying to think about contemporary issues, is to think about what health promotion interventions, what behaviour change, what health education and social norm interventions, which are classically health promotion interventions, how those can not always have the desired effect that they might seem to have. And so I'll talk about this in other times, but there are many health messages which don't seem to be what they are. Drink aware is a fantastic intervention to cast a critical lens on, and the tweet you can see there that came out today was about sharing the knowledge of how many units, what is a unit, and what that many units look like. But as someone that doesn't drink the weekly units, self-disclosure, conflict of interest, and all that, but as someone who doesn't drink those, I'm not gonna be as simplistic as to say that makes me want to drink, but effectively they are showing me what the minimum amount to drink is. So far from aiming at someone who's drinking 12 pints and suggesting that they should limit it to 6, there will also be people who occasionally drink 6, occasionally drink 4, but are now empowered to think 6 is okay, that's the minimum. And so that would be the Drink Aware organisation sharing that information, which is funded by all the large drinks producers, manufacturers, and has been termed as a health washing organisation, which is trying to fend off further government legislation, but is putting out a message there which evidence suggests is just as likely to change behaviour negatively as it is positively. These are contemporary issues in health promotion and give us a lens to look through and think, what is health promotion, what is it not, and what are some of the critical issues around health promotion. So in summary, we have some of our skills on the top board there from the International Union of Health Promotion and Education. I've put up this almost as a challenge really to think, what is health promotion? This is my simplistic, this is the best diagram I can come up with which shows what health promotion is. There are clear overlaps with public health. We could spend a long time thinking about and talking about what is public health itself. In this diagram, it's meant to be more than just organisations which call themselves public health, be they local or national. It's about a concept of public health. I didn't have enough room on the diagram to pick apart what that might mean, but if we think of a concept as public health, then the most simplistic way of thinking about it is that health promotion for me is consideration of the behaviours, again cautious of using the word, but the way that people are able to live their lives and the support and help that we can give them when needed to help them make changes. So we've touched on issues of empowerment, power, coercion, whose health is it, whose right is it to decide that we need to change. All of those sit within public health and health promotion. Health protection, classically, last year I would have drawn that, I will say not now naively, I would have drawn that separately and said it was something different. But what I've seen in the last year has been a kick up the bum to remind me that health promotion and health protection have lots of synergies, lots of overlap. And if I could make this diagram a flexing diagram that moved out and was like a piece of jelly, then I would, because in different countries, at different times, facing different global issues, different health threats, then I think definitely we could see that these move. What I've tried to do is so there's a few questions for you there to look through, and you can pause the video and have a think about those, and we'll address some of those in class. But for now, what I've tried to do is set the scene for what health promotion is. It's a contested term, to say the least, and that's not to say that health as our starting point is a contested term as well. It means different things to different people at different times. Even a definition would be contested. But what is health promotion? Where does it sit amongst public health? What are the skills needed to do this thing called health promotion? What is health promotion not? Where can health promotion go wrong sometimes? And these talking points are designed, this what I've just covered is designed to help us think about that, and when we move forwards and we think we're doing health promotion, to at least have a kind of critical insight into what it is not, where it sits, whose responsibility is health promotion. I hope you found this interesting. Next to the video I'll post some of the readings and some other resources. If I've forgotten to include them, we'll talk about them. And I hope you found this interesting. Thanks a lot for watching.